Without sexual activities, persistent erection. And is it effective? Some effect. So that is useless. Painful persistent erection without detumescence. Detumescence means the correct term for accident. These are not you need to know about practice and CPUs. So young, if you look at practice, what are your worries? I consider Tarandu as a young person, don't think about Tarandu's personality. Martin Tarandu as a young person, he is practice, what are the possibilities? Secondary courses.
Sickle cell disease.
Sickle cell disease.
Pyronees.
Recent activation. Recent activation. It was extremely high control. Okay, coming back to pancreas, which is a little bit above the penis. So those are the investigations as a house also. Any patient coming with acute severe epigastric pain, please do order those 3 investigations. No harm. Okay? Chest X-ray, right? Am I there? Severe, it has been severe epigastric pain. What is your clinical diagnosis of this patient? Forget about the past history. You said acute pancreatitis. Why do you say acute pancreatitis? How do you diagnose acute pancreatitis? Okay. No. Typical epigastric pain. Sudden severe epigastric pain. Radiation to that. Relieved by bending forward. Why does it relieve by bending forward? Because it is a retrograde. Yeah. So when there's pancreatitis, the pancreatic capsule is stretched. So when it lies supine, there is more pressure on the stretched capsule, which can cause pain. When they lean forward, some patient and one can be start bathroom and will kill them. So you rephrase your question on so if you don't get the correct answer, you rephrase your question in a different way. Right? So you can rephrase your questions again and again. So that's a typical history. Anything else? I'm asking diagnostic criteria. Just because you have that, can you diagnose pancreatitis? 3 times. Upper limit of no. 3 times upper limit of no. 2. What is the third criteria? Anyone? Third criteria? Imaging evidence, CT evidence of pancreatitis. Having said that, we don't do CT regularly for pancreatitis to diagnose pancreatitis. I will tell you indications of CT pancreatitis in a while. So those are for Atlanta criteria to diagnose pancreatitis. Atlanta. There are 3 criteria. If you have 2 out of 3, you can diagnose. Number 1, clinical, typical history. Number 2, biochemical, serum amylase or serum lipase more than 3 times upper limit of normal. Lipase is sensitive, more sensitive than amylase. And third one is imaging evidence. If you have 2 out of 3, you can go over that. So obviously one indication to CT is if there is a diagnostic doubt. Let's say you have typical history and amylase and lipase is normal, then you may have to go for CT. Or if the patient does not have typical history and amylase is high, you have to go for third one. So if there is diagnostic doubt, one indication to CT in pancreatitis is there is a diagnostic doubt. We have already discussed one thing. We discussed others later. So that is 2 out of 3. So this your patient has 2 out of 3. Okay? What is the amount? 343. What was the upper limit? 80. It depends. Lab to lab it depends. So there is no, you can't write 80 universally. Right? So 80 into 3, 240. So generally in acute pancreatitis, it comes as more than 1000 marks. But by guidelines, if you go by guidelines, more than 3 times upper limit of normal. So what are the courses? He excluded courses in history. So what are the courses? How do you remember? I get smashed. Ilan master leke vende I get smashed. Or we get smashed. Ilan master leke vende na that's not I get it. It's for your. Don't say idiopathic as the first answer. Look for idioms. G, goes, very common. The rest I would say is a common answer. E, methanol. T, trauma. S, okay. O, scorpion bite. Scorpion bite. Now, exam में यहाँ लिखा हुआ है बोर्ड क्या है वो पता नहीं होगा. Okay, वो पता नहीं होगा. Those are just to remember as theory. But in the history you don't have to ask. वो उससे क्या होगा? M, mouse. A, autoimmune. S, steroids. H, hypertriglyceridemia or hypercalcemia. E, ERCP. D, drugs like acetylprin, even PCM overdose, not just one time, but PCM overdose. You will see a lot of PCM overdose patients in medicine department. आपका नाम ये अनुबंध है कि PCM बोला. वो लगातार ले रहे हैं PCM बोला. Very good. Para kau di sini ada kita. Di sini ada. Oh hai. Hard lagi ini bisa ada. Saya mahu para bila bori media. तो लोग एक कौन कौन यार बता देगा तू. So that those are the courses. So now, pathophysiology of pancreatitis, you have to remember, it is the first week of symptoms are mainly due to the systemic manifestation. Now, in pancreatitis, the pancreas gets inflamed, and there is autoactivation of the enzymes within it. Right? So, the first week symptoms that entry is called interstitial idiopathic pancreatitis. And during this episode, there are so many cytokines released. Because of that, all the systemic manifestations, the WBC goes up, CRP goes up, and the patient will be tachycardic, they have respiratory problems. So all these symptoms, organ failure, everything is due to the systemic cytokine release. And if usually with your conservative management, most of the pancreatitis will settle on its own. There is no exact treatment for pancreatitis. You have to just practice a management protocol. Right? There is no dengue we are managing dengue condition. So similarly, pancreatitis management usually they settle after the 3 to 5 days. Some people they don't settle. They deteriorate after 3 to 5 days. So towards the end of the first week, this is first week. Okay? Towards the end of the first week, into the second week, they deteriorate. In the second week, the deterioration is due to local complications. Either pancreatic necrosis, pancreatic abscess, or pseudoaneurysm rupture. acute fluid collections. All these are local complications. When the patient deteriorates, you have to suspect local complications. All these local complications that I told, abscess, necrosis, can be detected by CT scans. Another indication of CT in pancreatitis is if your patient who is diagnosed pancreatitis does not settle with your conservative management, that means when you suspect local complication, you have to go for CT. Especially if you suspect necrosis, you have to go for contrast enhanced CT scan. That's another indication. Okay? You will understand up to that point. So if you get a diagnosed patient with acute pancreatitis, there are so many causes that we have discussed. So there is what are the investigations that you can do to diagnose, to identify a cause for the pancreatitis? Ultrasound scan of abdomen. So basically, all the patients who are diagnosed as having pancreatitis, acute pancreatitis, needs ultrasound scan of abdomen to exclude gallstone disease. We don't do ultrasound to diagnose acute pancreatitis because ultrasound is not a very sensitive investigation for the pancreas because it is a retroperitoneal structure. There are so many bowel gas overlapping, so it's not a very sensitive investigation. Ultrasonographer might say there is evidence of pancreatitis. Pancreas is inflamed, edematous. Good ultrasonographer will say, but our aim of doing ultrasound scan for all the pancreatitis patient is to diagnose gallstone disease. Even if the patient is alcoholic, you can't just put the blame on the patient. I personally put the blame on the patient. But we have to do ultrasound. If ultrasound shows gallstone, it could be due to gallstone also. So basically, all the patients of diagnosed pancreatitis needs ultrasound scan. Number one. This is the investigation protocol to find out cause. So those who do not have obvious cause, that is alcohol and gallstone, those are the two obvious causes. If they do not have obvious cause, you have to investigate for a second line. So what are the second line things? Common one, trauma, of course, you know, easypical andana, rust learner andana, motorcycle andana, mamsadina andana. So basically, this H, hypertritis and even hypercalcemia. But those two investigations, you don't do it at the acute setting. Because anyway, when the patient is having pancreatitis, because of saponification, calcium levels are low. So you will not get a clear idea. So once patient settle only, if there is no obvious cause, if once patient settle, patient needs serum triglyceride levels and serum calcium levels to find out whether it is the cause of his pancreatitis. That is, if there is no obvious cause, you don't have to do these two. If patient is alcoholic or if patient has gallstones. So if the triglyceride level is more than 1000 milligram per deciliter, without obvious cause, you can attribute his pancreatitis due to hypertriglyceridemia. We recently had a patient, young patient, more than 2000 triglyceride levels. So then your management is management of hypertriglyceridemia to prevent further attacks. Patient needs fibrates, patient needs sometimes plasmapheresis. And serum calcium. So if there is no obvious cause still, let's ultrasound normal, no alcohol, triglyceride normal, calcium normal. And the patient is young patient, less than 40, young patient. You have to think of genetic causes. So then patient might need genetic studies. And also you have to think of anatomical anomalies, like pancreatic divisor. Pancreatic divisor. What is pancreatic divisor? How many ducts are there? Two. What is the name of the major duct? Duct of Versa. What is the minor duct of Santorini? Major duct of Versa, minor duct of Santorini. So, in divisor, major duct drains through minor papilla. So large amount of output try to come through a small opening. Obviously there will be back pressure causing pancreatitis. So that is divisor. The major duct drains through minor papilla. Right? So pancreatic divisor. What is the diagnostic investigation? If you want to see ductal anomaly, MRCP. Right? If the patient has no obvious cause, everything is normal after this. The patient is an elderly patient. Let's say, how old is the patient? 54 patient. No alcohol, no gallstones, triglyceride normal, everything normal, calcium normal. Unlikely to have divisor, you have to think of tumors. Because pancreatic neoplasm, initial presentation can be a acute pancreatitis. So then patient need a contrast enhanced CT scan, pancreatic protocol. So this is another indication of CT. I have told 3 now. If the patient, if there is diagnostic delay, diagnostic doubt. Number 2, if the patient fails to improve within first few days, we are thinking of local complications. Third, if you fail to find out a cause by preliminary assessment, when you suspect pancreatic neoplasm as a cause, patient need a CT. Tell brother, but again, I don't know what that is. Hypercalcemia can cause. If the calcium levels are high without other obvious cause, you can attribute this is hypercalcemia induced pancreatitis. Yeah, that's why we don't do it at acute setting. We can't be low forever. Pancreatitis, it's settled at some point. So they do that. That's why you don't do this investigation as an initial investigation. To find it out as a cause. You do it. I will discuss that later for another reason. Okay? Pancreatitis, there are several scoring systems. So many. Right? Why do we have scoring systems in medicine? In general, in medical field or whatever field, what are the advantage of having scoring system? You can assess the severity, number 1. Yeah, you can prognosticate. Those who have severe pancreatitis have bad prognosis compared to those who have mild pancreatitis. Anything else? To design the management plan. Okay, maybe to follow up. Anything else? To decide on the place of management. Those who have severe pancreatitis needs HDO-ICU care. You can't manage in the ward. And those who have severe pancreatitis needs to be referred to a tertiary referral center. Cannot be managed in a district hospital or base hospital. You know, to decide the pace of management. Is it important for research purposes? Yes, yes. And policy making, research purposes. Those are competition answers. Competition answers. Right. Any other reason? Yeah. So basically, those are the advantage of having a scoring system in medicine. Right? So for pancreatitis, there are so many. There are old ones and there are new ones. There are pros and cons of each. Old, some are good. So what are the old ones? What are the things that you know of? Transcends. Glasgow. Glasgow को हिलने हैं लोग कौन सा है?
Scotland.
What is the other name of Glasgow? Newry. Both are same. Anything else? Huh? Apache. Apache में Apache. What does it stand for? Acute physiology and chronic health evaluation. Apache 2. Apache 2. Acute physiology and chronic health evaluation. Anything else? Balthasar. Name making हो गया देखिए.
Team.
और किसी बोला? So these are the old ones. New ones are revised Atlanta. Determinant this CRP ASAP BICEP. Likewise, so many. You don't need to remember everything. Okay? So these are the. But if you go by these things, these are all biochemical markers. All biochemical markers. Do you know Ransons? What are the parts in Ransons? Ransons has two parts. What are the two parts? One not admission. That is a misnomer. At the onset of symptoms. So that is a problem with Ransons. We do not get the patient at the onset of symptoms. So that is a problem with Ransons. So one of the drawbacks in Ransons. And then next one at 48 hours from the onset of symptoms. Sometimes we get the patient at 48 hours. So we can really apply Ransons. Right? So they are at onset and 48 hours. What are the criteria at onset? How to remember? I remember it as GAL. G for glucose, A for AH, L for leukocytes, L for LDH, A for AST. 48 hours is a standard mnemonic. C-house. I don't know what C-house means. C for calcium, H for hematocrit, or PCB, O for partial pressure of oxygen, B for base excess, B for blood urea, S for sequestration. So these are in all standard textbooks. The advantage of knowing these things, you know what investigations to be done in a patient with acute pancreatitis. Obviously, you have already made a diagnosis. So serum amylase, chest X-ray, ECG, those things done, you have come to a diagnosis. And you have done ultrasound abdomen to exclude gallstone disease. So those investigations are done. And obviously you need basic liver profile, baseline electrolytes, those things they will never change. But if you know these things, you know investigations. Blood glucose, so does the patient need RBS? Yeah. So that is one of your investigation in patient acute pancreatitis. Leukocytes, patient needs full blood count. LDH, we don't routinely perform, but there's a place. AST, if you get a full liver profile, if you get AST. Calcium, what do you expect? Hypocalcemia because of supplementation. Hematocrit how can happen? Full blood count. PA how can happen? ABG. Base excess second? ABG. So that's another investigation. Blood urea, obviously blood urea creatinine. Sequestration क्या क्या है? कोचरा fluid के लिए scan ने क्या है? Chest X-ray क्या है? एक से नहीं कोचरा fluid establishment का है. So those are that. But again we don't currently practice this. But you need to know at least Ransons. Glasgow is the same, but it has albumin. So if you go by these two, all these are biochemical set of biochemical markers. It does not give, there's nothing clinical in it. The only clinical thing is age here. Right? All the others are biochemical. You have biochemical dependent. That's the problem of this. Apache 2 is not only for pancreatitis, these are for pancreatitis, but Apache 2 is not for pancreatitis. For any patient with HDU or ICU, you can do Apache 2. Any patient. Don't keep any valuable, we don't need to think that. How do we do that? So Apache 2 is not it's non-specific. The advantage of Apache 2, if you compare these two, it takes chronic health evaluation into consideration, whereas these are all biochemicals. If somebody asks what is the advantage of Apache 2 or these two, this has taken chronic health into evaluation into consideration. Balthasar is totally CT index. The degree of pancreatic necrosis. You don't need to know grades. Balthasar is a CT index criteria. It doesn't assess anything other than local complication of pancreatic necrosis. So again, not a good one. Whereas these are good ones, new ones. They are like drawbacks. We will remember only revised set data. Just forget about that. CRP, your basic CRP. If it is more than 150, you can predict it's a severe pancreatitis. But again, it's a single criteria one. What if the patient has second UTI and cholangiosis along with it? Anyway, it will be high. So it is again not a good criteria, but that's new criteria came into practice, but it's a single criteria. Yes, and by some just forget it. Okay. So forget about vitamin base also. We go to revised set data. I told you first week symptoms are systemic symptoms. So they get organ failure. So one component is organ failure. Second week symptoms are local complications. So pancreatic necrosis. And organ failures can be transient. Less than 48 hours. They settle. It can be a persistent. That is more than 48 hours. Necrosis can be sterile necrosis. It can be infected necrosis. So depending on this, we categorize patient into 3 categories: mild, moderate, severe. जल्दी से लगे दिया करने पर मैं और ये पसंद दिया कर so mild, moderate and severe. What do you think? What is mild? No organ failure, no necrosis. Obviously, patient no organ failure, no necrosis. Moderate can get transient organ failure and O. Patient can have both. Okay? And O, sterile pancreatic necrosis. It becomes moderate. What is severe then? Persistent organ failure and O, infected pancreatitis become severe pancreatitis. Amount of thermal that is mild, moderate, severe pancreatitis. And I have already told how to diagnose necrosis. Contrast enhanced CT scan. And how do you see a necrosis? What do you think? Necrotic segments, does it have blood supply? So if you do an enhanced scan, it will be seen as non-enhanced area. Non-enhanced area on the CT. Right? So that is CT. And if the patient, your patient deteriorates towards the end of the first week, you do a CT and it will show enhanced, non-enhanced area, suggestive of pancreatic necrosis. How do you know it is sterile or infected? Because I told you first week symptoms are systemic. Do they have cytopenias and systemic inflammatory response syndrome? SIRS? Yes. Is fever is a writing of SIRS? So does fever indicate infection? WBC. You have already told in Ranson's leukocyte is a marker. So WBC high pancreatitis. So does high WBC mean infection? No, again. So how do you diagnose sterile or
Drainage.
you can do guided aspirations and that's for H and ABS. That's one way. Any other way? Usually these bacteria are gas forming bacteria. So in a CT, if you see retroperitoneal gas, that also suggestive of infected pancreatitis. Because if you have not done laparotomy or any intervention, needle test or anything, there is no gas in your retroperitoneum or even in your peritoneum. So in a CT, if you see retroperitoneal gas, that means there is an infection. Right? So either you have respiratory consent for ABST or retroperitoneal gas in a CT also suggests of infected pancreatic necrosis. So that is the diagnosis of necrosis. How to diagnose organ failure? What are your organs? What are your organs you are worrying about? What is the commonest organ to affect? Lungs. Lungs commonest. So what are your organs? We are mainly worried about lungs or respiratory system, CVS, and renal. It can be any organ. It can be myocarditis. It can be VIC. It can be anything. But these are the main key organs. How to diagnose organ failure? Have you heard modified Marshall score? Again, you don't need to by heart these scores because everyone has smartphones, can get access to Medicalc and you can type the parameters. But you need to know what are the investigations to be ordered to calculate Marshall score. So what are the clinical criteria needed to calculate Marshall score? Right? You need to know what are the grades of Marshall score. So organ failure is diagnosed using modified Marshall score. Modified Marshall score. So respiratory system criteria is PaO2 to FiO2 index. How do you get the PaO2? ABG. What is FiO2? What is the FiO2 that we are breathing in now? What is the percentage of oxygen in air that we breathe? 20. Right? So we do an ABG. If the patient is on 60% oxygen, if you do the ABG on 60% oxygen, then you have to put FiO2, PaO2 ABG, FiO2 60. If you do ABG on air, FiO2 is 20. So that is FiO2, percentage of oxygen in the given air. So that is the RS index. CVS, we go by blood pressure. Renal, we go by serum creatinine. If you know what are the things to order or check, you can obviously calculate. There are online calculators. So using modified Marshall score, you check whether patient has organ failure or not. Organ failure or not. So then if your organ failure is lasting more than 48 hours, it's persistent less than 48 hours. So likewise, you can categorize the patient into these categories. And as we discussed before, this Categorization of mild, moderate, severe is needed to plan your management, to decide on place of management, and to decide on referrals, transfers, and also for policy making research purposes. Right? Okay. Any questions up to now? You need to understand this concept. Any questions up to now? No. So, I'm going to take the other people and read for you. Take that here. Like to put up? Here now. Bible are going to we are not going to give them? Yes. I'm going to take out casual get the post casual get the but if you vote, I can get you down here then. You discuss the management. So if you know these things, you know what investigations to be ordered. Patient acute pancreatitis. So management. Mild pancreatitis. One of the medication are with pain. Obviously, this patient needs analgesics, good analgesics. There was a hypothesis, morphine can cause intra-body spasm. It's known side effect. So therefore, theoretically, morphine cannot be given because if there is intra-body spasm, there is a back pressure that can burst the pancreas, but it is no longer accepted. So even morphine can be given for pancreatitis. Okay, because intra-body spasm theory is not practiced. It is not happening in real theoretical activity. So one is analgesics. And the cornerstone of management, or the most important thing in management of pancreatitis is hydration. Hydration. You have to vigorously hydrate the patient, provided they don't have heart failure or renal failure. Heart failure is vigorously hydrated, tata bye even though heart failure is right? So provided they don't have other medical comorbidities, vigorous hydration. IV fluids, maybe 100 cc or 120 cc, you have to give them liberally. Right? But again, if it's a mild pancreatitis, you can titrate. The patient can take oral. We discuss oral intake. IV fluids has to be given, provided they don't have medical comorbidities. What is the fluid of choice? Heart mats. I told you when you are doing so much of fluid, like in burns and pancreas, the fluid of choice is regulactate. But if they have renal failure, it is not the fluid of choice. Because I think explain the reason. If you give more fluid, there is a theoretical risk of metabolic acidosis. Because all these fluids are acidotic. But heart regulactate, how does it overcome the risk of acidosis? Because it has bicarbonate. It has lactate, which is converted into bicarbonate in the body. Right? So fluid of choice is regulactate. Analgesics. Patient can be also given PPI, proton pump inhibitors. What about feeding? when we were medical student, pancreatitis concept was pancreatic rest, nil by mouth. No feeding if you diagnose pancreatitis. But it has changed now. Provided patient can take orally, provided patient has no pancreatitis or persistent vomiting, right? If they can tolerate orally, you can feed them. There is no contraindication. If it's mild acute, very unlikely that patient is having pancreatitis or persistent vomiting, right? So, and the other thing is antibiotic, I forgot, because presentation they have nausea, vomiting, so antibiotics. Analgesics, ibuprofen, PPI, antibiotics, feeding. Feeding, provided they have ideas, vomiting, sometimes can very well. Generally, pancreatic pain is increase after meals. If they don't have that, so if they can tolerate, you can feed them. Recommendation is low fat, high calorie diet. High calorie diet. So these patients, mild acute pancreatitis, generally they get better in second day, third day, or fourth day. You can discharge them. They get better. Okay. Move other things. Mild acute, moderate and severe. Moderate and severe. Moderate and severe pancreatitis. Preferably should be managed in HDU or ICU. Who are the patients who requires ICU, not HDU? What are the indications for ICU admissions? If the patient has 2 or more organ failures, patient needs ICU admission. 2 or more organ failure. Or even if it's a single organ failure, that is respiratory system requiring ventilator support, although it is one organ failure, right? So I told you it's 2 or more. But if it's a single one and that is respiratory requiring ventilator support, that patient also needs ICU. All the other patients can be managed in HDU setup. Okay? Pancreatitis. Because there's in acute pancreatitis, there's a lot of fluid loss and extravasation. That's what they say. So you have vigorously hydrate them. Yeah, vomiting and there's deep frustration, all these things. That's why you got to hydrate these patients better. Otherwise, they will go into complications, renal failure. So you are pushing the patient to organ failure. You are pushing the patient to moderate or severe if you don't hydrate the patient better. So hydration does not necessarily mean IV freeze in mild. If they can give orally, you can give them orally. But very unlikely that they take orally to fulfill the entire requirement. So you have to combine oral and IV together. You can balance it out. Right. So moderate severe preferably should be managed in HDU ICU. Analgesics, of course, same. IV fluids, yes, vigorous hydration, recollected. PPI, yes, no change. Antibiotics, no change. Feeding, go by same principle. They can tolerate, no ideas, no vomiting, can feed. But generally, when it comes to moderate and severe, very unlikely that they tolerate a normal diet. So, if they can tolerate, at least give liquids. At least give liquids. Now, when we medical students, CPI pancreatitis, TPA, total pancreatitis, not anymore. We hardly give TPA to pancreatitis now. Right? Enteral feeding is better. Why enteral feeding is better than parenteral feeding? It's more physiological. Anything else?
Stress ulcer.
Huh?
Stress ulceration.
Psychologically also better to the patient. Anything else? Reduce complications of parenteral nutrition. Organ related, line related complications. Anything else? Okay, all these TPA related complications are prevented. Anything else? It prevents transmigration of bacteria. දැන් මම මේ ඔයාලා රූම් එකට දාලා වහලා තියෙනවා පැය 47ක්. මේ කටහරි දෙකෙන් හදන කන්න. Similarly, if you keep the gut bacteria starved, you starve them, then they will migrate out. So these common cells can become virulent, can cause infections. So that's why even if the patient is on TPN, try to give something entirely to prevent this transmigration. So that's another complication of TPN. So that's why generally we are very restricted, very much restricted in giving TPN. We try to give enteral as much as possible. So enteral feeding is not contraindicated. You can consider. Sometimes you have to combine, depending on the severity, depending on the degree of ILS, you might have to combine enteral with parenteral. It need not to be total parenteral. Need not to be total parenteral. So you can give enteral or parenteral duration. And or parenteral duration. Okay? Then you come to the question that they have is antibiotics. Still most of the doctors give antibiotics. Most. VPs, VS, surgeons, physicians, everyone. That is wrong. Because can they have fever? Just because of pancreatitis? Just because of pancreatitis can they have fever? Yes, I told you, because they can have cells. Can they have high WBC? Yes. Can they have high CRP? Yes. So none of those are indication to give antibiotics because that's a normal sequelae of acute pancreatitis. So antibiotics are not routinely recommended. For God's sake, not routinely recommended. So antibiotics are indicated if patient has infected pancreatic necrosis. Infected pancreatic necrosis. So if your patient fails to improve after 3 to 5 days, you go for a CT. And if CT shows necrosis with retroperitoneal gas, that means patient is infected necrosis. Or if you do aspiration and culture ABS is positive necrosis, then antibiotic is recommended. Then the antibiotic antibiotic of choice is carbapenems. What are carbapenems? Examples? Meropenem, because it has a good pancreatic penetration. So if you start this antibiotic correctly for the correct patient, it has mortality and morbidity benefits. It reduces mortality and the morbidity both. But if you start antibiotic irrationally, what will happen? You will increase antibiotic resistance only. So antibiotics are not routinely recommended. Only indication for antibiotic as far as pancreatitis is concerned is infected pancreatic necrosis, which is evident by either culture aspiration or gas in the retroperitoneum on CT. The other indication for pancreatitis antibiotic, if patient has other infections, not pancreatitis. Let's say patient was on a catheter. Patient developed catheter associated UTI with pancreatitis. Obviously, patient needs antibiotic, but the antibiotic of choice is not carbapenem. What is sensitive to your UTI? Or let's say, can this patient develop pneumonia with pancreatitis? Yes. Pneumonia, UTI, another infection, cholangitis. Can the patient develop cholangitis with pancreatitis? If it is close to pancreatitis?
Yes.
Obviously, that patient needs antibiotic, but that is relevant to that particular infection. As far as pancreatitis is concerned, the only indication is this. Do you all understand what I am saying? Okay? Clear? Any questions? So that is the indication of antibiotic. So then you can also consider DVT prophylaxis in the management, especially if they are elderly patients, obese patients. DVT prophylaxis is also part of management. What else? Another 2 points that we could discuss: place for ERCP and place for surgery in pancreatitis. Place for ERCP I will discuss with Boston pancreatitis. place for surgery? Where is the place for surgery? Is it common or very limited? Very, very limited. Very, 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 very limited. Right? So we do surgery if the patient has pancreatic necrosis. When to do is the next question. Are we trying to do it as early as possible? As late as possible? As late as possible. To reason, what are the reasons to delay this is, now these patients are having necrosis. That means patients having moderate and severe. They have organ failure also, most likely. So you don't want to give general anesthesia to a patient who's already compromised. You wait until the organ systems recover for you to do a major surgery. Pancreatectomy is not easy surgery. It carries high morbidity and mortality also. So then, that's another. You wait for at least 4 to 6 weeks. And the other advantage of waiting 4 to 6 weeks is your necrosis is very much organized. So surgery is comparatively easier to remove it when it is very much organized. Just void off, you remove it. And the other reason is you wait until the retroperitoneal inflammation settles. So retroperitoneal structure, if you go in initial days, retroperitoneal is very angry looking, vascularized. So if you do it, you cause more harm, more bleeding, more morbidity, more mortality. So you wait for 4 to 6 weeks, your retroperitoneal inflammation settles. Organ system settles, inflammation settles, it gets walled off, and when you wait, sometimes they don't require a retrosectomy. Sometimes, if it gets fibrous, if patient clinically gets better, you don't have to remove it. The need of surgery may not be there, right? So you can wait. But if patient deteriorates despite of your management with the infected necrosis, if patient becomes septic, of course you have to go and do something. You don't wait until that time. So surgeries can be either intervention rectal, percutaneous drainage. Percutaneous drainage is one, or laparoscopic, or retroperitoneoscopic. You can scope එක බඩහරහා පෙරපෙරම හදන්නේ මෙහෙන්ද retroperitoneoscopic drainage or open surgical drainage. So those are the options available. You don't need to know that much. Just remember percutaneous, laparoscopic, retroperitoneous, or open. So we can remove the necrotic segments.
Poet. Huh? Poet now.
This is a picture of the pancreas that we did necrotectomy. So she had near total pancreatic necrosis, almost entire pancreatic necrosis. We have removed almost entire pancreas. She's still alive. She's doing very well. Mother of two, 34-year-old, ghost of pancreatitis without trouble. So pancreatitis can be disastrous. Some people go home, some people go home with coffee. Deadly disease. That's why we surgeons respect the pancreas like we respect women. Okay, so this is an retrospective that we did, I think in February. Place for surgery. Then we come back to gallstone pancreatitis. If the cause is alcohol, apart from your management, if the patient goes home, will not drink coffee, you have to strongly advise them to stop alcohol. If the cause is steroid, you have to stop the offending drug. Sorry, steroid or other drug. Go to second and have a go to hunt. Go something beer like वो खाता है गाली किया मारना पेड़ को मैं Ghost on pancreatitis. Those who have gallstone are at a risk of getting gallstone pancreatitis. So gallstone to cause gallstone pancreatitis, that gallstone has to come all the way down to the common channel. So there are several prerequisites. It has to come, so there should be a wide fatal cystic duct, otherwise it will not come. And the stone should not be too large. If it is too large, before it causes pancreatitis, it will cause obstructive jaundice. If it is too small, it will not come and block the ampulla. It just passes away. And there should be a common channel. So there are patients who have separate channels without a common channel. Those patients will never get pancreatitis. Lucky guys. So there are prerequisites. Like, well, if all these are fulfilled only, they get pancreatitis. We have a patient who came with a plastic hole in the rectum. So I asked how did it happen? He's a painter. Then I asked him to pay. He said, "Palle hai lamai ka kya cell lamai ka dekha mama baitha. Mama tamse सीखते क्या हेलू है?" मैं हमारे सालमा के अंदर है अटैक में तो इन्हें उधर तेज तंगा है तो lamai cell lamai का देखला मियाँ पालन चाहिए बैठना अरे बोले rectum में. So that was his story. There are so many prerequisites for that. India batted board. Saro नहीं बोले plans करके अगर नहीं बोले अरे मैं बोलो किस तरह के मैं ये वाली सारो नहीं बोले हेलर तो एक मत चाहिए बोले सा हेलर से एक तरह से पाती तो नहीं हेलर से डायरेक्ट नहीं बोले तो CLO there are supplements literalized, only that huge ball can go into the rectum. Okay. Likewise, there are plates. We remove the ball. My SR, as a registrar, the SR put his entire hand and put the ball out. It was so easy to put it. And 2018, 1st of January, the surgery that I did was 70-year-old with gas under diaphragm. Laparotomy, open, so fecal peritonitis. The part of registrar के अंदर आता, मैं अभी मेरा आपको रहती, अभी तो कल तक राम पे क्या लगा रहा है इनके, अभी होते हैं राम पे ना दिया अच्छा राम पे कहाँ होती राम मुझे लगता है तो बार बार किहल बोल गया किहल मोटा ही नहीं किहल किहल है बड़ी पहले है तो मोटा ही ये सियार नहीं कि हम लोग का नोट पैट so similar scenario I have a picture of kiहल body also kiहल body those things can happen. There are really similarly, it goes to pancreatitis. So coming back to gallstone pancreatitis, if it is small enough, if it is not too big enough, it can enter common as channel. But having said that, most of the patients who develop gallstone pancreatitis, when you examine them, they don't have a stone here. It comes, translates the block, does the damage, and then migrate. It's called transient infection and migration theory. So just a transient infection, when pancreas is like a woman, ළඟ කියොත් ඇහැක් නැහැ. පොඩ්ඩක් ඒ ළඟ පොඩ්ඩක් ගෝස් කරන එක නැගලුවා, they can get pancreatitis. It depends, some pancreas are not like that. Some women are not like that. So that is ghost on pancreatitis. So it was actually studied by I don't know his name. What he has done was he has taken stool samples of all the patients with gallstone pancreatitis and washed it. And he found that most of them have gallstones in stools. So that means it has done its damage and then it has passed out. So that is transient infection migration theory. So if you go by this, do they need ERCP? No, because most of the time they don't have a blocking stone. It has already passed. So ERCP has a very limited phase in gallstone pancreatitis. The only indication for emergency ERCP is if the patient has pancreatitis plus cholangitis. If patient has both acute pancreatitis, that means the offending nidus is still there. It's blocking the common channel causing pancreatitis. It's blocking the common channel causing cholangitis. So this is the only indication for emergency ERCP. Because this patient has two deadly conditions. This is deadly, this is also deadly. Right? So you have to relieve it. The only indication for emergency ERCP. How to diagnose cholangitis? Which triad? Charles triad. What are those?
Fever,
RSV, fever with chills,
jaundice.
Anyway, RSV pain and efficacy pain will be there with pancreatitis. So if the patient is having fever with chills and jaundice, you have to assume that this patient has cholangitis and then do emergency ERCP. If the patient has acute pancreatitis with obstructive jaundice, that means without fever, those patients does not need ERCP acute setting. You can do it electively. Why are we very limited and reserved in this ERCP business of pancreatitis? Because ERCP itself can cause pancreatitis. Right? But we are taking that risk in this condition because patient has two deadly conditions. Right? Clear on that? So that is the only indication for ERCP. So then what is the long-term management? Management of gallstone pancreatitis is the same as the management of pancreatitis. But there should be a long-term plan. What is the long-term plan? Take the gallbladder out. Because if patient gets one attack for gallstone pancreatitis, getting another attack risk is about 30 to 50%. Recurrence rate is 30 to 50, quite high, 30 to 50%. Therefore, you have to remove the gallbladder. Otherwise, even if this episode is mild, next episode may be moderate and severe. Patient might not go home also. So therefore, you have to remove it. So the recommendation is if patient has mild acute pancreatitis, remove the gallbladder in the same admission. Once as mild acute secular and so then you do a laparoscopic polycystectomy and remove it. Index admission. That is the recommendation. The patient has a mild acute episode. Before patient goes home, you remove the gallbladder because recurrence rate is so high. But if it's a moderate or severe, recurrence rate is still high, but patient is having organ failure. Patient is not fit enough for general anesthesia, so you have to wait for some time. Right? So then you go for elective cholecystectomy, taking the chance of a recurrent attack. Because if you give general anesthesia to this patient, you are compromising the patient. Right? So therefore, you wait for elective cholecystectomy. Maybe 4 weeks later, you can take the gallbladder off. That is the place for surgery in gallstone pancreatitis. What are the long-term complications of acute pancreatitis? Pancreatic abscess. Okay, it's acute setting.
Pseudocyst formation.
Chronic pancreatitis, especially if they get recurrent acute attacks. Anything else?
Pseudocyst formation.
Pseudocyst formation. Anything else?
Pancreatic carcinoma.
Yeah, if the patient has significant necrosis, they can get exocrine and no endocrine failure. So those are the complications of acute pancreatitis. Any questions? We discussed that with chronic pancreatitis. Any questions with regards to acute pancreatitis? Is it clear? Or you already knew all these things just to please me, or else it will be who are the owners of the female patient? You are coming because of that patient. So who are originally and yeah, we remove only the necrotic part. We don't remove the other part. But lot of problems, property part and then duct open. So there was a leakage. So then we have to put ERCP and stenting. So it's not easy. Pancreatic surgery කරාම දෙඩා ගෙදර යනකම්ම කරත් මනුස්සයට හරිම those patients we have done sphincterotomy before, they will not get healed. There should be a sphincter, otherwise there will not be a trans infection. Just passes out. Sphincterotomy instead of cholecystectomy. It doesn't eliminate the risk completely. And yeah, if there is no evidence of persistent stone there, right, you would go for a cholecystectomy but not for a ERCP, because ERCP is not a, I would say, can cause a lot of problems. He's still in the ICU. HDU. Post ERCP pancreatitis. That main patient. You still need testing. He's asked, but does he have organ failure? He has organ failure now. He is noradrenaline dependent. I think patient has moderate acute pancreatitis at the moment. Whose patient is that? Can you put Marshall's sequence in? So apply. You learn like that. If you get a patient with acute pancreatitis, hereafter, when you take the history, that's how you should learn. That's how I consider extraordinary people. Okay, categorization visualization to be calculate Marshall score, see whether what is the category, then you can, in your summary you have. Then you will never forget. You will never forget. I even as household you will do that. So that's called the evaluation. See, the picture they were here,